Greetings, everyone. This is PARM 2223, Unit 11, Seizure Lecture, Part 3. And as I mentioned, I'm trying to make these into smaller bites so that they're a little bit easier for you to digest. So let me know if you prefer this rather than one larger lecture, which I think most of y'all would. So let's move along. We talk about management of seizures. Let's talk about the wide variety of management of seizures. Let's talk about what people see, what you will see when you go into the home. Remember that many people with seizure disorders live fully independent, normal lives. You would probably never be aware of it. You also encounter people that live in an assisted capacity, whether it's somebody in their home or in a group home or even in a assisted living or skilled nursing facility or various other compositions, especially when their seizure orders are very severe. So one of the common treatments for seizures is a drug called Diastat. Now, Diastat, in a nutshell, in its most basic form, is basically diazepam, Valium, in a gel composition. Now, why would they do this? Well, as paramedics, we've given rectal Valium for way before I became a paramedic, and this is my 30th year in emergency services, so it was old hat then. But I can tell you in the times I've given it, and honestly, there's only been I could probably count on both hands the number of times I've actually had to give rectal Valium. In the times I've given it, especially in children, every single time, after about 2 minutes to about 5 minutes, in that period, there tends to be a period of apnea or pseudo-apnea. And what my hypothesis is, that's about the time that the Valium in its oil-based form that we carry is absorbed and hits the bloodstream through the mucosal membrane, and boom, you have a kind of a rapid rise in bioavailability, knocks down the respiratory drive. They're already compromised. So every time you give rectal Valium of any type, you need to be ready to bag them. I'll talk about that more later. I'm probably getting ahead of myself, but the gel composition, you tend not to see that because I think that the gel slows down absorption, distributes it better. You don't get such a rapid rise in bioavailability, therefore you have less adverse effects. Now, I have written down here it comes in 2.55 and 10 milligram compositions. That's actually, there's quite a few others out there, so that may not be accurate. There's something called the AccuDial, nice and fancy, so you can give it more than once. So it's a multi-dose rectal applicator. You see the picture there. It's very simple. It's designed for parents, panic parents, lay caregivers with minimal training to be able to do. But when you give it, it's the same considerations when you're given IV or IM Valium. You have to watch for respiratory depression. You have to watch for other side effects, so on and so forth. So let's move on. Now this is one, and this is in one of the discussion board posts. This is a VNS, a vagus nerve stimulator, and these are fascinating, and they've been around for a while, and they are fairly common for refractory or kind of difficult seizures. I'm looking at my notes, and if they're approved for children over 4 to 5 years of age by the FDA, and it's used to treat both partial and focal seizures as well as complex seizures that don't respond to standard seizure medication. So basically what they call drug-resistant epilepsy or refractory epilepsy. And in essence, I don't know if you can tell from the image, might have to look close, is it's very much like a pacemaker. The technology is very similar. It looks very much the same, except instead of implanting the pacemaker wire on near the SA node of the heart or in the chambers of the heart, you actually have it wrapped around the 10th cranial nerve, the vagus nerve. And instead of sending impulses down to the heart, it sends impulses up to the brain. And the idea is that by sending these micro pulses up to the brain, it will stop the seizure before it progresses to a complex seizure. And the complications are less, the recovery's quicker, and you don't have all the other problems. So this looks like often a pacemaker. What's really interesting to me is that it can be placed in an outpatient clinic. It usually does not always require general anesthesia, which blew my mind, right? So I'm not sure exactly how that is. So how does it work? Well, the nutshell is, remember we talked about auras? Well, a patient feels whatever their aura is, whatever their sensation is, they feel that coming on. And they wear it, looks like a watch. It's a magnet. And they can simply place that magnet. And, we think of a magnet as like some great big horseshoe-shaped thing. It looks very much like a watch. Place it over their chest, over the pacemaker. And as long as it's over the pacemaker, it starts sending those impulses up and tries to arrest the seizure beforehand. That said, they're not supposed to hold it over there. It's supposed to trigger, and there's some various safeguards in that. So we don't know exactly why it works as well as it does, but we do know it works. There's some thoughts that vagus nerve stimulators may help control seizures because they actually cause increase vasodilatation, increase in blood flow. Also thought that the electrical impulses will actually raise certain neurotransmitters important to control seizure threshold. So on and so forth. Now here's another thing: is some of them are prompted. They're semi-automatic in that they also through the vagus nerve will sense heart rate, and about 80 to 90% of patients undergoing seizures will have a spike in heart rate immediately before a sympathetic surge. Well, remember the 10th cranial nerve, the vagus nerve, is part of the parasympathetic system. So sending those impulses, that the VNS will sense that spike in heart rate, and sometimes the newer ones will actually preemptively send those impulses up to the brain. So it's pretty cool technology, actually. So how effective is it? Well, it can reduce seizures 20-30%. It's usually not something that you would use by itself. So it'd be used in combination with multimodal therapy. So it'd be used in combination with anti-epileptic drugs and other, methods of controlling seizures. So, but some patients do have reduction in seizures. Some patients have it completely resolved for most of the part. So it can be a very effective, very useful tool, especially for patients who have debilitating seizures. So here's an example. Now, this magnet, I've never seen a magnet like this. All the magnets I've seen look like watches, or I guess actually now you'd say they look almost like Fitbits, and could easily be mistaken for that. Except of course they don't have anything that lights up. Now there are apps that can actually link, just like your insulin pumps. These VNSs can be integrated to the app and report their function and use, and even have their parameters adjusted wirelessly, right? So when we talk about these, very similar to when we talk about pacemakers later on, let's take how are they classified? Well, the output current, pulse width, the signal off time, which is the period almost, if you think about the signal off time, signal on time, think of it like when we talked about I to E ratio when we talked about vents. The stimulation frequencies in hertz, battery life, similar to pacemakers. Battery life is between 5 and 10 years. It also depends on how often it gets used and it needs to be used. It's a pretty simple process to change it out. So this is a picture of what the magnet may look like. Again, this is really relative, but you can see how it could easily be mistaken for a Fitbit or something like that. And you see basically what happens is when they feel a seizure coming on, if the machine does not trigger itself, they simply move their wrist over the over the VNS, and it's supposed to trigger it. So sometimes we get asked if there are side effects or adverse effects. So here's what can happen. They may have uncomfortable sensation. They may have tachycardia, so on and so forth. So how can you turn off the VNS? Well, if you actually take the magnet and hold it over, not just move it over, but hold it over the the VNS, it will actually put it into pause mode, it will stop it. So if you have problems with the VNS, yes, moving it over will trigger it, but you can actually place it over it and tape it there, and it will not deactivate, it will make it go dormant. Oops, sorry about that. Yeah. Okay, so can you use the VNS in an emergency? Well, possibly. You know, you're sitting there, you're struggling for IV, seizures come on, you see they have a VNS, give it a shot. What does it hurt? It's a non-invasive intervention, fairly quick to use. If a patient wants to use it, of course, let them use it. A lot of times you'll have parents use it. But here's the thing. Sometimes parents forget, or patients forget, that the holding the magnet directly over the VNS deactivates it. So they like, why won't it work? And they, hold it there, and they actually are inhibiting its function. So something to keep in mind. So what are some of the common side effects? Well, these are things people complain of: sore throat, hoarseness, shortness of breath, tachycardia, coughing, nausea, and or vomiting. It's not, none of these tend to be very severe and tend to be transient. I will say, though, that sometimes these can be signs that the VNS is self-triggering when it's detecting the potential for seizure activity as well. So how do we manage these in a pre-hospital setting? Well, you basically manage them just like you do a pacemaker. You make sure you don't put the defib pads over them. And other than that, you go about your day. So it's not a severe issue as long as you're aware it's there. Now, if for some reason somebody has a pacemaker on one side and they have a VNS on the other, and you say, where would I put my pads? Go anterior, posterior if you have to. So a DBS is kind of, it's what we call deep brain stimulation. It's a little bit different than a vagus nerve stimulator in that it does not send impulses up the vagus nerve. It is a probe that's directly implanted into the brain to stop seizures. So these are patients that have very severe seizure disorders. They can, and often caused by extrinsic causes such as tumors or Parkinsonian disorders. They also are used for obsessive compulsive disorders. They are used for dystonias from chronic antipsychotic medication use. A wide variety of things, not just seizures. So these deep brain stimulators, the technology is very similar, but instead of wrapping around the vagus nerve, actually is a probe that goes up, and the probe goes spike, if you want to think of it like that. It's probably oversimplification, directly into a specific part of the brain to stimulate that to stop whatever it is supposed to stop. Our treatment is pretty much the same. Now, there are also external VNSs, and they're FDA approved, but they're still kind of out there. They're non-invasive. They are not approved for seizure control, and the literature on whether they actually work for seizure control is really kind of sketchy. Or I shouldn't say sketchy, inconclusive. But they have been used for severe cluster migraines, severe headaches, and the principle is the same, except they apply the impulses through the skin, kind of in a broader pathway, and hopefully trigger the vagus nerve and fire up into the brain and help terminate some of those other problems. So you'll sometimes hear people call them or the same way, but they're not really used for seizure control. So some basic pre-hospital considerations, stuff you probably already know if you've been an EMT for a while, is when somebody has a seizure, we contain them, but we seldom restrain them. The only time I've ever actually gone hands-on with these patients is when they're trying to get up, when they're trying to, where they're in danger of falling down, when they're banging their head, and they're on a concrete floor, something like that, where they're going to cause themselves further harm. That's not saying we just stand back with our hands in our pockets. We certainly can contain them to the site, protect them, but as far as the full-on rodeo, we try to avoid. Keep in mind that these patients, very much like when you have a diabetic who's coming out of his hypoglycemic episode, As they come to, they don't know why you're there. They're still confused. There's usually a period of violence, or I shouldn't say usually, there can be. So a smart and prudent paramedic makes sure there's nothing within grabbing range that's going to cause you harm. And keep in mind that where these patients have their seizures. In the bedroom, what do we find in bedrooms? Guns. If it's in the kitchen, what do we find in kitchens? Knives, pokey things. What do we find in garages? Everything, right? So keep that in mind. As they're coming out of their post-ictal period or after we've administered medication, of course, SpO2 and end-tidal CO2 is always wise because we're worried about respiratory problems. And here's a little bit, just a street bit of advice. Almost all seizure patients, their seizures will terminate before your arrival, just because they're short to under 5 minutes, and it takes us time to get out of our lazy boy recliners and go get to the rig and do our thing. We very seldom arrive within 5 minutes of onset of seizures. But if you find a patient who has that second seizure, or they're still in seizure when you get there, that should automatically be a little bit of a red flag for you. That's just a street tip. So, basic stuff you may not know. What we know is that the quicker we treat status epilepticus, it reduces the number of persistent seizures, it reduces their complication, it reduces their ICU stay. We also know that the opposite is true. The more we delay treatment, the worse they do. And there's lots of reasons for this. So please, 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 don't, if you find somebody in seizures, don't drag your butt treating it. Get on it quickly. The research is pretty solid on this. So hypoglycemia. Well, it does happen in seizures due to it happens in 1 to 2% of non-diabetic patients. So quite more often in diabetic patients. So all these patients check their sugar. I've heard people, there's a recent article in GEMS talking about, well, if they don't have a diabetic history, you don't need to check their sugar. That's bogus. Absolutely check their sugar. There's so many different complications, including from some of the medications that are on that article. I don't know what that guy was thinking when he wrote it. He should issue a retraction because it goes against every bit of evidence, and quite a few physicians called him out on it. So anyway, check your sugar on your patients due to the instance of hypoglycemia and treat it if you find it. So we always talk about time as the first line treatment in seizures. The question is, what is the dose? Well, the dose is basically 5 minutes or less. And again, it comes back and that's 5 minutes from onset of seizure, not after you get there. And it comes back to the red flag. We very rarely see patients in seizures when we arrive. So if they are, presume they're in refractory or prolonged seizure and go to your next option. So what are your next options? Benzodiazepines. And there's 3 big ones that are commonly used in pre-hospital medicine right now. Now, diazepam is our benchmark benzodiazepine, much the way morphine is our benchmark opioid. It's the one they're all compared to. It's it's pretty long lasting, 2 hours or so. 75% effective on the first dose. However, the big issue is respiratory depression, especially in the elderly and infants. You have to be ready for that. It happens. It happens more often than you'd like. And depending on the protocol, 2 to 10 milligrams IV. Rectally, it's 5 to 10. I think I'd have to go back and look, but I think at Ada County we've actually gone to a weight-based dose. So if you're going to be interning at Ada County, go ahead and look that weight-based dose up. Now, it says the max dose of 20. I think I have it later. The increased risk of respiratory depression and other adverse outcomes increases when you go over 10 milligrams of Valium. Not that, but a lot of agencies, Valium, this is the only benzodiazepine they carry, or they carry this in Versed. So it's, you may not have a choice to go to something different. Just understand that when you get above 10 milligrams, whether it's your repeat dose, whatever the case is, your chance of respiratory depression and other complications increase significantly. You may not have a choice. So midazolam, Versed, is probably the most common one used in pre-hospital medicine of all the benzos that I see. It also has the biggest risk of hypotension and the biggest respiratory hammer. So I'm not a big fan of Versed compared to Valium, but I'm a little bit old school that way. The one advantage that midazolam has, almost all the time, I won't say every time, but all the compositions of IV Valium that I am familiar with, IV and IM, are oil-based. And what this means is that it makes it unsuitable for intranasal administration. That's why you don't see Valium given intranasally. Versed is not oil-based. So if you're going to go intranasal, Versed is the drug you want to go to. Its dose is 0.5 to 2.5, up to a total of 5. Some places just start out at 5 IM. Nothing wrong with that. There are infusions. Lots of different compositions for this. But just keep in mind, if you want to make them quit breathing, midazolam is a good way to do it. Now, lorazepam, Ativan, the research is pretty solid on lorazepam for seizure control. I personally am not a fan of it because when we carried it, it just never seemed to work. But a lot of people swear by it, and the research seems to support it. Now, lorazepam has to be refrigerated for about or it has to be discarded after about 2 weeks outside the fridge. So it is subject to variations in temperature, and that may be one of the reasons why we didn't see as good of a result in the pre-hospital setting locally. Now, why is it why is it one of the first line indications, especially in the ER, for benzos for seizures? Well, what we know is that it has a pretty strong bioavailability, and it tends to hang out it tends to control seizures longer than diazepam because it has something what we call second pass effect. So it just tends to cause longer seizure suppression with less respiratory depression. Now, that said, I've seen infants that we've given lorazepam to have that pseudo-apnea period as well. So just because you're given lorazepam does not mean that you can just be less than diligent. So anyway, you may talk to other people, especially a lot of physicians really like Ativan when they can get it for seizure control. Let me see if I got anything else in my notes here. Nope. Moving on. So how do benzodiazepines work? Well, basically, GABA is an inhibitory neurotransmitter, and benzodiazepines, so does alcohol. The alcohol doesn't have the effect on seizure threshold. Benzodiazepines work through that, the GABA complex, the GABA mechanism, and help suppress seizures through that effect. They also help inhibit some of the sympathetic neurotransmitters that actually promote seizure activity in the brain. So it's kind of a neat two-ply mechanism of action there. Now, as I talked about, we're always concerned about respiratory depression after I beat that one to death. But let's talk about something else I want you to do. You really need to look for underlying causes. Just because somebody has a seizure threshold, you need to play Sherlock Holmes here. That's who that picture is, that statue. You need to play Sherlock Holmes and make sure there's nothing else going to sneak up and bite you in the butt, especially if you're going to treat and release them. So what if they're refractory? What if they are refractory to benzodiazepines? Well, this is a big red flag, but we do know that they are more likely to be refractory for seizures that last longer than 20 minutes. So even primary epilepsy that normally on any other day would respond to a nice healthy dose of Valium at 10 milligrams IV or something else, will be refractory after about 15 to 20 minutes. And that just, the ATP gets exhausted, the neurons get hyper irritable. It just is not enough. So they have to go to other mechanisms. And the reason we don't carry these in the field is every single one of them has some pretty significant side effects. When you compare their safety profile to benzos, there's no comparison, which is why these, we don't use them in pre-hospital medicine very often. Now I want to talk real quick. When you look at the ones that are refractory, these are the ones that we also look at and say, why are they refractory? And one of the big ones is alcohol withdrawal. Now, alcohol withdrawal syndrome, out of all the various types of alcohol withdrawal syndrome and DTs, only about 10% of the most severe actually result in refractory seizures. So even alcohol withdrawal syndrome often respond to benzodiazepines until they are prolonged, but there's about 10% aren't. These are very difficult patients to manage. So these are the patients that sometimes you'll end up giving. You'll end up giving in excess of 40 milligrams of lorazepam. 40 milligrams of diazepam in 4 hours. And some physicians will, and it just will not be controlled. These are bad news. We won't wait that long to get a hold of them. So Dilantin, phenytoin. This is often given as an infusion. You'll encounter this on interfacility transports, not uncommonly. All sorts of problems with hypotension. Hypotension is your biggest problem with most of these meds, but also dysrhythmias, and if it infiltrates tissue necrosis. Most of your anti-epileptics, these medications do not mix well with other compounds, so they have to be in an isolated line. They will be on a pump. You don't want to dink around with this and eyeball this. Now, there's also something called phosphophenytoin, and this is expressed in phenytoin equivalents. So it's the metabolite of Dilantin, of phenytoin, but it's actually quite a bit different. So the dosing is different. Do not program your pump for Dilantin when you have phosphophenytoin, because they're quite a bit different, even though their mechanism is very similar. Phenobarbital is another one that's been around for a long time. And it's typically used after both benzodiazepines and phenytoin or Dilantin fail to abort the status epilepticus. Now, it also works through GABA. It's a very broad spectrum, very effective seizure suppression medication, and it actually may be more effective when alcohol withdrawals at play. But it has big risk of hypotension, big risk of respiratory depression. It also has some other really bizarre side effects, such as Stevens-Johnson syndrome, which is a rapid onset tissue necrosis. Rapid onset and severe. That's just systemic, and all sorts of bad things happen. So, moving on. Depakote. Depakote's been around since, believe it or not, the 1800s, and but has been in common medical use since about the 1960s. It's on one of the most. It's one of the WHO's list of essential medications, and it's been available as generic, which is why it's cheap and it's widely available. Now, it's also very effective at seizure control, about 70% effective. It's taken orally, but also as an infusion. Again, this is something that you would need to do on a pump. And actually, in some studies, it's actually more effective than phenytoin. But again, that depends on the etiology. So I'm just looking at my notes here, make sure there's nothing else I'm forgetting. Keppra. Keppra is another medication. Also, you run the risk of Stevens-Johnson syndrome, so we're really concerned about that. It's these infusions, Keppra infusions, have a weird bolus followed by infusion matrix, and it differs a little bit depending on facility. So again, you need to double check and be very cautious with this. So we talk about prolonged seizures. And prolonged seizures is what we're looking at. Again, when we deal with prolonged seizures, figure out what's causing it, whether it's alcohol withdrawal, tumor, head injury, whatever the case is. 99% of the time, your seizures will respond to benzos. So when they don't, you need to be very cautious. So what are the consequences of prolonged and refractory seizures? Well, big one is hypoxia, both absolute and relative. Now, we talk about relative hypoxia. They're oxygenating, just not enough for their muscular activity. hypercarbia, both because of impaired respiratory function and increased muscular activity. They're producing more byproducts from this increased muscular activity. They become hypercarbic. Because of the muscle activity, they also often will be hyperthermic, sometimes life-threateningly so. And all three of these combine to make sure they're going to be acidotic. Now, I want to really, I'd like to call these the 4 H's, okay? In all your, you start adding these things together. I don't care if you're talking about toxicological emergencies, you're talking about opioid overdoses, you're talking about restraint and agitated delirium, or you're talking about seizure control, you're talking about anything else. You start piling on hypoxia, hypercarbia, hyperthermia, and acidosis, you are really facing a recipe for fatal outcomes. These 4 H's I would have tattooed on your forearm, so every time you put on your gloves, you look at it and are reminded that these are the things that kill patients. So especially when you're like, this patient is not responding to my benzos, I need to now do something more aggressive. So what's more aggressive that's in our pre-hospital setting? RSI. So we do a RSI, or delayed sequence intubation, whatever you want to call it, however you want to compose it. And they're still hypercarbic, hypoxic, hyperthermic, and acidotic. They will arrest. They will arrest on you, and it'll be an ugly freaking code. So there's the expression resuscitate before you intubate. So you have these refractory seizures. You've given your benzos. They haven't resolved. You're looking at your RSI. Make sure you oxygenate, ventilate, cool, or allow heat dissipation, I should say. Those things will correct the acidosis before you push your drugs. Otherwise, they'll Brady down and code in seconds. Just so you know. Let's talk about the role of intubation in seizures. Well, it's I really shouldn't say it's controversial. It's not controversial. EM docs agree there's a point when you need to do it, and that point is earlier rather than later. However, every time you do it, you're going to get a neurologist that comes in, and he's going to yell, he's going to throw a temper tantrum, and he might even throw stuff. I'm not exaggerating. And he'll complain because now he can't get good neurological assessment. All of which is true. But, and I wouldn't say this, but I always want to say, well, the dead are really easy to get an assessment on. Okay? So why are you if you're going to pull the trigger on this, you need to have clear objective criteria, and that criteria is not, well, my protocol said so. You need to be able to look that physician in the eye and say, he was hot to the touch. His SATs were 70. He was choking on secretions. He was entitled CO2 was whatever, and he was refractory to benzos. I did not have time. You need to paint this picture of the clinically unstable patient in objective terms that everybody can agree on. And here's the thing: he's still gonna yell and scream, throw a temper tantrum. But you're going to be on solid ground. And honestly, as a provider, you need to be in a good position to do that. You need to be always thinking about those things anyway. So, understand that sometimes you're going to walk in there and they're all just going to yell and scream. And you may just have to bare your butt cheek and say, okay, take a chunk out. Let me know when you're done so I go about my day. And just accept it. Understanding you still did the right thing for the patient. It's not fair. It's just the way it is. So what agents are you going to use in your peril if you're going to RSI them? Well, it really depends on what your options. I know there are physicians who use propofol, but again, propofol can cause hypotension. If sucks is all you have, then that's what you have. I'm cautious with sucks in this case, because when you have the hypoxia, hyperthermia, hypercarbia, and acidosis, you often will have already a spike in your potassium, and we know that succinylcholine and potassium is a bad combination and can cause fatal outcomes. So it may be your only option, but you need to be really cautious of that. Rocuronium is a good option, except it lasts a while, so you gotta make sure you get the tube or have backups. Midazolam, you're already going to be given you're already going to have loaded them up on on benzos, so you don't get a lot there. Ketamine, I'm cool with. I'm cool in this setting. However, keep in mind, ketamine is a dissociative anesthetic. It doesn't control muscular activity. So you really are going to need a paralytic with this. So that brings you back to which of your paralytics you're going to use. If you have the option for rocuronium, that's going to be your first choice. So we'll say that, let's backtrack a little bit. This patient is going, it has recovered. They want to go home. They don't want to go to the hospital. So which ones are you really going to press on going to the hospital anyway? Well, obviously, first-time seizures that, without previous diagnosis of an actual legit seizure history. That's the big one. You dig into it and they're non-compliant with their meds. There's trauma-associated alcohol use or withdrawal. And that's the big one. Got to actually dig into the alcohol withdrawal. And remember, alcohol withdrawal is relative. Okay? So just not to belate this too much, but you have the patient who normally drinks a fifth and they've had a beer. They don't drink a fifth every day, but all they've had was 1 or 2 beers. They are still in withdrawal, even though they're still drinking. The seizure is abnormal for the patient. So this goes back to being a detective and find out, okay, well, the seizure, it looked like XYZ. Is this normal for them? Do they normally have this duration, this time clock activity in both extremities, stuff like that? Of course, make sure, and I'm not going to hammer this too much, your cognition and capacity assessments for your legal refusals. Make sure they're hemodynamically stable. Check their glucose before they go, and make sure that if they have another seizure, somebody is there with them. I don't like leaving these patients alone in their homes. Certainly don't allow them to drive themselves home. If you have to, I want to point this out. If you let somebody get behind a wheel after they've had a seizure, I don't know if there's been any case law on this, but ethically, I think that you have an obligation to call law enforcement and have them intervene to keep them from driving home. Now, before I do that, I would tell them, listen, if you try to get behind that wheel, I'm calling a cop. So let's find somebody else to come take you home, or let's find a Uber driver to take you home, or whatever. Find alternatives, work with the patient. But don't let them drive home till they've been evaluated by a doctor. Let's see here. Yep, pretty much it. So if you have any questions, you know where to post them. I hope this has been useful and for you, and I'll see you out there.